really delighted that you can join. Julie and I work together at UCLH in Queen Square, and this is our first experience of doing a webinar with this group, having done a few in other fora, and this is our day-to-day clinical practice. So what we'll present and hopefully engage is the idea of a practical approach to this. It's not at all meant to be theoretical. The most important message before we get into this of the detail is please do feel free to participate. Julie and I are very relaxed. The more informal and the more numerous the questions, the better. If not, you'll just hear the two of us droning on for an hour, and you really don't want that. So just feel free to put any questions in on the Q&A bit of the webinar. You guys are all very experienced with that, and I will make sure we deal with those. So yes, it's going to be a joint presentation shared between the two of us. Okay, so welcome indeed, and please do keep questions coming throughout, and I'll make sure we go through all of them. So you guys here are already on board with this message. You know why you're here. You're here because you see symptoms. And I guess if there's one of the first messages we'd like to get is for those of you who don't, who have colleagues who don't feel this is an issue, this is an issue. Here's data just showing that there's prevalence of these problems like constipation and incontinence in the general population in the dark bars. About 1 in 10 of us are constipated, about 1 in 25 of us mess our underwear on a weekly basis. That's a lot of people. But if you think that's bad, it's appalling for our MS patients, where the estimates are of about 2/3 of patients experiencing constipation by the standard criteria, and over half who experience fecal incontinence on a weekly or fortnightly basis. So this is a big deal. And as well as those particular symptoms, which is what we'll focus on, there are some rarer conditions which can occur in this group, which is not really the focus of this presentation, but I'm very happy to discuss them, like omegacolon or prolapse of the bowel, some of which occur as complications of these previous symptoms. But our main focus will be on constipation and incontinence. And as you can imagine, these are hugely life-limiting. So data on the left-hand side about spinal cord injury, where patients were asked to score the severity of their symptoms in terms of how much limitation they get, where 6 was the worst and 0 was the least. And you can see for spinal injured patients, bowel function is second only to mobility. And we did a similar study in Queen Square a few years ago now for MS patients on the right. You can see bowel function was the #1 issue for these patients. And these weren't patients who were referred to the GI clinic. These were patients who were being seen in their neuro follow-up. And what are the symptoms that bother people? Well, this is data from a big survey we did internationally with a variety of neurological conditions, spinal injury, MS, Parkinson's, etc. And the largest cohort we had were MS patients, as you'll see in bold in the middle there. And fecal incontinence and urgency accounted for about 40% of people's concern. So fecal incontinence and unpredictability of their bowel working, and then constipation were the primary things which really bothered people about their bowel. And the issue of how long things took in the bathroom and how much of their day it ate into, and therefore how limited their quality of life became because of that. And the other thing that came out from this survey was a kind of slightly depressing thing, which is that patients have often seen a variety of healthcare practitioners before they get much joy. Okay, so the median number is they've seen about 5 healthcare professionals before they get their problem taken seriously from their point of view. And that's kind of depressing data. And therefore, for that reason, on the right-hand panel, they get their healthcare advice only about a quarter of the time from us, healthcare professionals. A quarter of the time it comes from social media, and a quarter of the time from peer support group. That's not to say that these are bad sources of information. It's just to say that surely we should be doing this more. If this is such a prevalent problem, and if it's such an intrusive problem for our patients, as we've shown on that limitations study, it should be something that we should be taking more seriously. And of course, all of you on this webinar are taking it seriously. This is why you've joined. But as I say, the message is also to reach out to those who don't. And the final thing is that it has complications. Once you develop GI symptoms, the association with anxiety, with depression, with frequent urinary symptoms increases. So not only are these burdensome, they also have an impact on other aspects of our patients' lives. And of course, the other way of looking at this set of data is that it's an opportunity for us to find these patients. If you're seeing a patient with significant anxiety or depression, but they haven't voiced any bowel symptoms, maybe that's the elephant in the room. Maybe it's a thing they can't talk about.
if you're getting frequent UTIs, of course, most people in specialist centers will now think about their bowel, but sometimes you'll be surprised, I'm surprised rather, how often that is ignored. And I quote this is an international survey we did across these patients, and this chap, this is one of many in that report we produced. Although he only had an accident occasionally, he was scared all the time, and that is a real fear that patients may have these symptoms which we may consider infrequent, although if it was you, I'm not sure we'd see it like that. But the fear of that happening again is what really burdens patients. So quick bit of neurophysiology to understand how this arises and why it arises in MS. Obviously, there's this two-way communication between your gut and your brain. How do you know when you're hungry? How do you know when you need to poo? How do you know when you finish doing either of those things? Of course, messages are coming up from your gut up to your brain. And how do you move things along? Subconsciously, there's stuff which is pushing through based on the nervous system within the gut, but that is in turn controlled by hormones and nerves originating in your brain, which helps express that. So you're able to defer a bowel action if it's not the right time, but most of the work of your bowel is done without you're being conscious of it. So most of this is subconscious, autonomically mediated neural activity, but there's a conscious element to that. And this is a slide any of you ever heard me speak before will have seen, but I sort of use it quite a lot because I think people sometimes dress up bowel physiology to make it seem very complicated. Now, we're nowhere near as advanced in our understanding as the bladder physiology and bladder doctors are, but we have a sort of working understanding. To get something out of your bottom end, the rectum has to be full. Your brain has to know that your rectum is full. You've got to be able to squeeze your abdomen and the rectum to squeeze things out. You've got to be able to relax your sphincters or take the lid off the toothpaste tube, as it were. And then you've got to be able to put the whole thing back on to stop going to the loo. And ideally, you've got to do it in the bathroom where you brush your teeth as well. Now, beyond that physiology, there are a couple of other things that are worth bearing in mind. This slide is quite an old slide. It reported the only study was available then saying 1 in 4 people are incontinent. It seems to be a higher number now. And it depends on how you define it, as I say. But incontinence of gas is embarrassing. If any of you were to pass wind at a time it wasn't appropriate, it's a big deal. As a patient, it's the same. We may tend to say, oh, it's only gas, ignore it. It's not like having a whole motion, but it's still, if it stops you being able to go to work or to visit your grandkids or to be intimate with your partner, that's pretty important. How does it arise? It arises from direct neural damage. It arises from some of the autonomic dysfunction that arises from that. It can arise from the hormonal things that occur in relation to MS patients, and the location of plaques can be either cortical or in the axial spine and vertebral cord to cause the limitation. But there's also some non-neurological factors. The fact these patients often have multiple drugs, in particular bladder medications, can make constipation worse. Their mobility and appetite may also be impaired. Celiac disease occurs in about 1 person in about 80 in the general population. It's about 1 in 40 amongst MS patients. So it's certainly something which we see more often in the population. And remember, just because one has MS doesn't mean that you're immune from having other conditions, inflammatory bowel disease. In fact, that's more common as an autoimmune illness and cancers and so on. And the final thing to mention, which I'll also allude to before I stop talking, is the role of the microbiota. It's very clear that there is this role that the gut bacteria have in terms of how they mediate disease. And this is a kind of a summary slide of a very complex interaction, which we are just beginning to understand a tiny bit of, which shows that this whole thing about how nervous control of gut function occurs and how sensation and awareness of what's happening in your gut occurs is related to the bacterial flora you have. And it may be that we can alter some of that by altering the bacterial flora. That's very much an early set of data that's emerging in terms of our physiological understanding, and it's even early in terms of therapies. So practically, that's the background. That's why you're here. That's the sort of pathophysiology. But this is meant to be, as I said, a practical discussion. So my last 15 minutes before I hand over to Julie is to set the pace. What Julie does is to make the clinical assessments and treat the majority of these patients. I do most of
the talking and chatting and don't do isn't the work really. But what I want to do is just try and show you how we assess these patients. So we're strong believers in the diary. A symptom output in a question in a clinic tends to be rather limited. People either underestimate things because they're embarrassed, or they overestimate because they want to convince you that things are as bad as they feel. And of course, that's an important thing. They're not lying, they're just trying to persuade you it's important. Whereas a diary gives us slightly more measured information. It also gives us a historic perspective. People tend to, the other thing we do as human beings is to remember the most dramatic or the most recent things. A diary helps frame that. And whether you want to use visual things like the Bristol stool form as a way of engaging patients, that's up to you. This is the diary we tend to use, but it's entirely up to you. There are objective scores that have been developed initially for spinal cord injury, but more laterally validated in MS as well. Very simple. This is a patient-reported thing. It takes about 2 minutes to complete. Simple questions. It gives you a score, and that score is very strongly correlated to quality of life. So it gives you an idea of how much the symptoms interfere with quality of life. Once you start treatment, if I can recommend any single paper, it's this one by Maureen Coggrave, who is a nurse who's working in Stoke Mandeville and Stanmore, where I work. And it's a really important description of the things that are available to us. It tells you when and how to use these things. And in some ways, in 20 minutes, I can't do much more than to point you in that direction, but to illustrate that there's a range of things that are available, and that range isn't an algorithm you have to go through stepwise. It's more a question of trying to tailor the symptoms the patient has to the treatment you offer. There's 3 things I say to patients we've got to try and aim for when we're trying to treat them. It's that they don't have any accidents, no incontinence. Number 2, that they don't spend too long in the bathroom. And number 3, that it doesn't interfere with their quality of life. I don't care if they open their bowels once a week or 3 times a day. It doesn't matter. You don't need to produce a stool with a certain frequency, of a certain consistency or size or shape or whatever. None of that matters. It's no accidents, not spending too long doing it, and not messing with the quality of life. And whatever of this it takes is what it takes. Now, there's a few things I just want to remind us of that are easily forgotten. Anal plugs, really helpful in terms of limiting people who passively leak. If they say, stuff just comes into my pants, my bowels are okay, but I just leak in my underwear, and then that makes my bottom sore, and that makes me get UTIs, and so on. This is data from spinal cord injury. There's equally good data in other neurological conditions showing that these things, they go in, like you can see there, a little plug like a little anal tampon, expands to fill the anal canal, so it forms a little barrier to liquid or gas leaking out, and when you need to empty it out, you can pull it out. Has the disadvantage of being a bit bulky, but if patients have poor sensation in their rectum, they don't really notice that bulky feeling in their bottom. But to minimize that bulkiness, there's these newer things called the Renew inserts, which seem to work just as well from the publications and are certainly much better tolerated, because the bit that's in your bottom in the anal canal where the sensation is much thinner and patients are unaware of it. Even healthy individuals are unaware of it when they put it in there. And it forms a little kind of like a little umbrella to keep things from coming out. And when you need to open your bowels, you just pull it out. This will hold on to gas and liquid very well. Now, next up for that is laxatives. If you look at laxative therapy, if you look at this figure, this is data from a variety of countries, European countries, Brazil, South Korea, whatever. And what you see is that whether you use laxatives or not, patients seem to respond as well. So in other words, how many patients have symptoms? You look at this and say, well, it makes no difference. Maybe Italian patients, according to this survey, had more symptoms than other ones, but actually the height of the graph is the same for each of these. So actually laxatives don't really help. Well, that's because I think we use laxatives badly. We tend to use our favorite one, or this is one I always use. That doesn't make sense. We've got to tailor the laxative we use according to what the patient's symptoms are. I'm not going to try and make you all gastroenterologists, but I can summarize. We went through all the papers on randomized trials for laxatives and tried to generate what is it that we're which patients did well with which particular class of laxatives. Because most laxative trials look for that mythical thing of the extra stool per week. And most patients don't give a damn about going to the loo 1 extra time a week. They're not going to say, oh, thanks very much, I've gone from twice a week to 3 times a week, my life's great. It's that thing we said before. No accidents, not spending too long, not interfering with the quality of life. And what we've shown, or we haven't shown anything, we just extracted the data from these other studies showing that there are particular symptoms on the left-hand side, you can see there, which particularly indicate which
should be our first line agent. We can make these slides available in PDF form for you, so don't worry about making frantic notes, please, but just do ask us questions as we go along. All laxatives have a very non-specific contact mechanism of action. They work by making contact between the bowel lining and the drug in question, and therefore they're unpredictable. Sometimes they work perfectly, sometimes they work not at all, sometimes they work too much and make you go too much. So we've moved along. So laxatives are still the first line of therapy once you've addressed the soiling things, but evolution of technology has meant that we've now moved from these very non-specific actions of laxatives, if patients don't respond to them, to think about more specific tailored agents. So there's drugs like prucalopride, which target a very particular receptor, the 5-HT4 receptor in your gut, to increase the strength of contraction through your intestine. There's drugs like lubiprostone, which target the chloride channel to increase chloride secretion into the gut. There's drugs like methyl naltrexone or naloxegol, which target the opioid receptors in your periphery, and therefore, if the patient is taking opioids as well for pain, they can reduce the constipation effect of that. There's drugs like laxatide, which target the chloride channel to increase via an indirect mechanism, like whereas lubiprostone is direct. And then there's therapies like biofeedback, when Julie will talk about this to a little extent, but where the patient can be trained with kind of operant conditioning to control the parts of bowel evacuation that they have control of. And sometimes you can do it with very simple equipment. Some people do it with much more complex equipment. The bottom line is that it's about engaging the patient, getting them to a good toilet pattern, using the simplest thing that helps them understand how to control their bowel. But I'm stepping into Julie's territory, and she's the one who actually delivers this rather than me talking about it. When it's been applied to MS patients, this is data from Giuseppe Preziosi, and he worked with us, looking at patients from their point of view of constipation on the left or incontinence on the right, before treatment in the dark bar, after treatment in the paler bar. You can see that there's a significant reduction in scores for these patients, and that this effect was related to whether they had sensation. In other words, Julie can work her magic with the biofeedback when the patients can feel what to do down there. And that kind of makes sense when you think about it post the event. In other words, if you're numb down there and can't control anything, then there's not much that you can do to train it. Whereas if you have some sensation, it can be worked with to improve. What's changed beyond that? The next step up the ladder of treatment is the idea of transient irrigation, and there are a variety of these systems now. They all have the same principle. There's a bit of it which goes into your bottom, like a catheter there, or these cone devices. Some you have to be held in by hand, like the cone. Some can be inflated to keep in place in the rectum, and then they all connect to a water reservoir of various volumes, and then you can pump that liquid from the reservoir, whichever reservoir it is, into the bowel, and there within the bowel it then causes a reflex contraction. And it's been studied in a whole variety of post-surgical and functional conditions, but the original and best work has always been in neurogenic, spinal cord injury, MS, spina bifida, where the strongest data is. And here's what you see when you use an irrigation. There's a person before their bowel action. This is something called a scintigraphy study, with your stools all labeled, and you can see that the bowel is full of stool. Remember that in a healthy individual, you and I listening to this broadcast, we have about 1.5 kilos of stool in our bowel. That's what your bowel is there for. It's a reservoir of poo. It's not harming you. It's not causing you any toxins to enter your system. It's there. It's what it's there for. It's a sewer. When you and I have a bowel action, we just clear out a tiny bit of our rectum. We leave about half of what's in our rectum still there. But when you do an irrigation, you can see you clear out the entire left-hand side of your bowel. So it gives you a much more complete emptying when patients respond to it, and therefore you don't need to do it every day. And when it is studied in patients with neurological disease, you can see it improves constipation, improves incontinence, and improves then neurological dysfunction score, that score system I showed you earlier on, compared to standard care in green. There's the transient irrigation bar in blue. And improve those things that patients care about, their quality of life aspects, how long they spent in the bathroom, how long they actually spent pushing and voiding, as well as their frequency of UTIs. So it has a net impact on these patients, and it does that in the long term. So there's some good long-term data since that original study in 2006, showing that about 2/3 of patients who start this with neurological disease are still irrigating at 5 years.
And specifically in MS, again, Giuseppe did some work, he was working with us, showing that you improve constipation and incontinence scores in a significant fashion, data from Queen Square some years ago now. So this is a therapy that's definitely here to stay. And it's here to stay, and NICE have pronounced upon it, because from data that was published by us about a year and a half ago, NICE then used that to produce something called a single technology appraisal, and have, based on the cost efficacy, shown that it reduces hospital admissions, reduces UTIs, consultations, and importantly, stoma surgery. So this has now become a mainstay of therapy in patients who failed lifestyle advice, failed laxatives, failed the newer therapies. If they're not suitable for irrigation, for biofeedback, then irrigation is in place. And here's the proportions of MS patients when we last surveyed this. About 50% of MS patients managed with those conservative therapies that we mentioned from Maureen's paper that summarized that I mentioned it on. About 40% are irrigating, and about 1 in 30 of our patients go on to get a stoma. In a very carefully followed up group of patients at Queen Square. How do patients choose whether to have irrigation or not? From the patient's point of view, the things that they care about most are, they care most about avoiding incontinence, not having to use it too often, and avoiding UTIs. That's what patients really care about. What are the risks of irrigation? There are risks in the early phase if patients are not trained. So this is why it's important to establish a service. This is what Julie will talk a little bit about setting up those two, so that we, number one, do the therapy safely, number two, do it most effectively. And doing it safely means avoiding these early perforations, because the risk of anything where you put something at the bottom end is tearing or bleeding from the bowel. And those are avoidable. The late cases are not cumulative. In other words, they don't add up. And if you look at what we estimate from the reports, the chance of irrigation is about 1 in 500,000. And to put that in context, if you go for a colonoscopy, any of you who've ever had that, the doctor who's doing the colonoscopy or the nurse doing it will quote you a risk of 1 in 1,000 of tearing the bowel. So 1 in 500,000 is a very low risk, but it's still a risk that we must always mention to our patients and train them carefully to make sure that it doesn't happen. What's on the future for the last 2 minutes? The future holds the fact that there is a neuromodulation. So many of you will know PTNS from the use in the bladder, been studied in MS patients. Santosh Sanagapilla, when he was working with us, did a nice study showing that that we had about a 60% response rate in MS patients, irrespective of whether they had sensation or not. So it's entered a place in our pathway of treatment, specifically for those who have continence problems. It doesn't seem to do anything for constipation. And there's a very clear difference between responders and non-responders, and a significant impact on their quality of life and their ability to function. Beyond that, as I said, there's 1 in 30 or 1 in 35 who go on to have surgery. We used to do a few of these procedures where essentially the appendix is brought out to the tummy wall, so the patient just has a little dimple like a second belly button, and when they need to, they pop a catheter into that. There's normally nothing in there. Because it's the appendix, nothing leaks out, so there's no need for a bag or a plaster or anything. But when they need to put it in, they pop a little catheter through there, irrigate about 1 litre through there. It takes about an hour for the whole thing. They do it a couple of times a week, and you get a completely clear bowel. That's before the irrigation. You know those studies now. And there's a post-irrigation film showing the entire bowel cleared out. And of course, there's some who go on to a formal stoma. And the careful thing to remember is that once you've chosen a patient, very selected, and counsel them very cautiously, most patients think it is the right thing for them. But remember that a third will go on to have some complications. So they need to, again, be counseled about that tremendously carefully. What does the future hold in the last 30 seconds? The future holds improvements in neuromodulation. It probably holds something to do with gut bacteria. I'm sure you've had talks before about the role of dysbiosis in the bowel, how that may be a contributory factor to driving the inflammatory cascade and demyelination pathway. And there's lots of supportive data for how the gut bacteria support the immune system to make this happen. At the moment, there's very little therapeutic data. It's limited to 2 or 3 clinical trials like this, showing that you can use these probiotics, either multi-strain or single-strain probiotics, to improve patient scores. I'm not saying that there's a recommendation of probiotics. I'm just mentioning this because somebody asked me to comment on this, that it's a thing that's evolving. We're not at the stage now where I can say to you, this is the right one or that's the right one, but more that this is an area of active research, or was before COVID and will be again, where things will certainly be there, probably not as a baseline or single therapy, but as a kind of icing on the cake. So once people say, I'm this much better and I need to do a bit more, then we can maybe say fine-tuning with probiotics, but that's all data to come. That's me talked out. I hope that's stimulated lots and lots of questions. I can talk faster, but I won't, and I'll hand you on to Julie now, and I'll mute myself. So thanks ever so much.
Thanks, Anton. So I'm going to be talking about how I've managed patients with multiple sclerosis with their bowel care remotely. And I've been really lucky at UCLH because I wasn't called in to work on the front line, having not worked there for 25 years. So I was able with the team to keep the bowel retraining clinics going remotely. We did them from home, which we're still doing. By telephone, we're not doing video clinics for these patients. It's working fine. We had to put the irrigation clinics on hold, the face-to-face first appointments, but all patients that had already seen me for irrigation for their initial appointment, I was able to follow them up remotely, and that follow-up care continued. I found with most of the patients that I was looking after with MS, actually, particularly if they've got a problem of incontinence, that it was actually beneficial for them, this full-on lockdown, because they weren't going out, they weren't going to work. So they were actually able to manage their symptoms better in lockdown. Next slide, please, Anton. So I'm going to go through a few case histories with you. So in summary, the first two or three, AP, a 61-year-old man that I've looked after who was diagnosed in 1992. He uses intermittent self-catheterization for his bladder. Importantly, recurrent UTIs. This is a recurring theme with patients. And he's also had a history of bladder stone that he had removed. He uses a wheelchair, can self-transfer. And I always ask patients, imagine that a newspaper journalist is on the telephone with us and they want a headline for their newspaper, your bowel problem, and sum it up for me in a few words before I go through everything in detail. And so I just get one brief sentence from them because that's what we're trying to look after. So for AP, a combination of a period of constipation followed by unexpected and unpredictable release of stools. Next slide, please, Anton. TB, a 54-year-old woman. By the way, I'll come back to these patients later. So she was diagnosed in 95. She uses intermittent self-catheterization for her bladder. She can walk about indoors, but wheelchair outdoors. And again, I don't get much advance notice if I need to have a poo. So always on guard, basically. And then this is a typical email that I got from a patient while in lockdown. And if you excuse my spelling mistakes and all the randomness of blocking things out, but her email to me at the bottom is, Julie, I've been using Parasteen for over 2 weeks, so she'd seen me just before lockdown. Unfortunately, still having problems. My bowel's pushing the catheter out. I've tried inflating the balloon. I have to keep re-inflating it. This is happening, help. And they need your help, and you need to be there via email. I cannot stress that enough. It's about access to care for these patients. So this is something that I sent her in reply. It's about looking after them, giving them a few top tips to keep them going, and basically keep in touch with me. Don't panic. It will be a bit up and down, so keep going with it. And as I say, I'll come back to those three. So remote bowel care, what do you need? You don't need very much. I'm currently in my loft bedroom and that's where I work, and all you need is privacy and to tell your patient that you are in a separate room with the door shut, so it's a completely confidential conversation as if you were seeing them in clinic. Most of them say, oh, don't worry about that, Julie, but actually it's important to point it out, and always tell them at the start of the phone call how long it's going to take. Half an hour minimum. They were taking half an hour, 45 minutes, these first appointments, as they would in clinic, and it means you're not shortchanging them. You need your phone, you need their email because you're going to email them the information, and your list of your bowel symptom assessment questions and the abdominal brace information sheet. And these were my tools in lockdown, which I still continue to use. Next slide, please, Anton. So I cannot stress this importantly enough to everyone out there, how massively crucial it is with these patients that you do a full symptom assessment. Don't generalize it. Oh, they've got a bit of constipation and they're being incontinent. That is not enough. You need these details. And Anton's already mentioned about the diaries before they come, which we sometimes use, but remotely we haven't done. So it's key, because you're then going to be able to use this assessment when you follow them up to go through any improvements. And don't forget, if you're following them up as I do in a month's time, and they've had the problem for a long time, there's not going to be any dramatic changes, but you've always got to give them hope and motivation. And if the fact is you can pinpoint a few little things in that assessment that have changed slightly, then you're guiding them through this process of your care. There's a few other things. Things like I think, what question is it? Number 3, frequency. Ask some details. It's how often do you pass something, even if it's only a tiny bit, with whatever you're taking. So that might be 1 to 3 days a week. And then you move that question on and you'd say, so on that day, how many times a day are you going? Because some of these patients are going multiple times per day, 10, 15 times a day, some of them, or every time they have a pee, particularly the women, because they're sitting, they'll have a little push. And that's part of the problem. So delve deeply. You don't need to be a bowel nurse specialist to be able to ask these questions, but they will give you all the information you need so that you can then look after your patient. And the other thing is, when did the problem start? We tend to blame everything on their MS. But some of these patients, all of these patients, have got a history prior to MS. And some of them you'll find have actually had problems with constipation since childhood. And that's really important, because if they've always been a kind of once every 3 day kind of girl, now they've got MS, we're not going to be aiming to get them going every day. So this assessment is key. Next slide, please, Anton. So this is what I teach them, and the team does as well. So this is the abdominal brace emptying technique, and this is what I email to them at the end of the appointment with specific advice that I've given them. So I'm going to talk this through with you now, because then you can do it with your patients as we do on the phone, and it works well, even though we're not seeing them in clinic and examining them. So we teach them to sit, if they can, with their feet flat on the floor, slouched forward, relaxing their shoulders. And the important thing is not to take a big breath in before they start, particularly if their stools are hard, because they end up straining with their head, neck and shoulders. So we say, referring back to Anton's tube of toothpaste, you don't want to squeeze right from the top of the tube. Equally, you don't want to strain right at the bottom. We're moving everything to the middle, like squeezing a tube of toothpaste, so it's going to be from your waist. So what I want you all to do now with me, as if you're a patient, is put one hand on the side of your waist with your fingers facing the front and your thumb looped around the back and your elbows sticking out at a right angle, as if you cross with me. Press quite hard on your waist and give me a big cough. Now, I'm not getting any feedback, so I would be with the patient, obviously. So that's great. You can probably feel your waist muscles bulging and widening against your waist. And these muscles, we use them every time we cough, laugh and sneeze. We're just not aware that they work like that. And these are the muscles that we want to use to open our bowels to help us to empty. So with your hands still on your waist, but this time without the cough, try and widen your waist out again, and you should feel those muscles working. So you can put your hands down now. So when you go to the toilet, you widen out with your waist. Once you're fully widened, you use those waist muscles to push downwards, relax a bit, then you widen and you push again. So you're using your waist like a pump to empty. And that's what I talk through with patients. So it's a really nice, simple technique for those patients with MS that can use those muscles. And most of them, when I speak to them, actually, we can start off with this. It's a really good start to bowel care. So next slide, please, Anton. So bowel care advice, as Anton's already mentioned, the importance and the aims are, we want to improve their regularity, but totally reduce any risk of incontinence, and also reducing their other bowel symptoms. So many of them will have pain, bloating, etc. So it's looking after all those symptoms. When you're going through their bowel symptoms with them, with that initial bowel care assessment, actually sometimes all they need is reassurance that what they're currently doing is safe. We don't have to change things for the sake of it. If they're not being incontinent, but they're only going maybe twice a week, but they're not getting pain or bloating, that's fine, it's safe. So reassure them, because they don't know what is safe and what isn't. It's about giving them bespoke care for what they want. Sometimes as medical people, we do the bowel assessment and we know what we think they should have. We know what they need to do to help manage that. But actually the patient might not want that. So it's always thinking about what the patient wants that you can offer and what they can cope with, not what you think would always necessarily be the best thing for them. Specific advice. So that abdominal brace emptying technique, which I went through with you, really simple, but then you go back to their symptoms. So for a patient that's maybe only going between 1-4 days a week, what we'd say is every morning after you've had a hot drink to produce that gastrocolic reflex, sit on the loo and just practice this for a few minutes. It's going to take time. It's like doing physiotherapy on your gut. Equally, those patients that are going multiple times per day, we say only go when you get a really, really strong urge in your bottom, and then use this technique to help you to empty. So that will help with that feeling of incomplete emptying and reduce that frequency down. So we're trying to move the gateposts together of regularity and frequency. Things you can add in on your second review with them. I phoned them up a month later after that initial assessment and advice giving that we've done. You can talk about maybe adding suppositories. If they haven't been for a couple of days, try using a glycerin suppository, or in lockdown, suppositories, I don't know if you guys have found this, have been impossible to get hold of. So we've been using microlax enemas instead. And obviously we'll give them laxative advice, but we have to be wary with laxatives because a lot of patients with MS have got this reduced sphincter function, so they can't hold on very well. And if you're giving them laxatives to help reduce constipation, you're going to potentially increase the risk of incontinence, which is always the worst thing to do. Loperamide's great. You've heard of loperamide tablets, but syrup much easier to titrate, and particularly if they're not necessarily getting diarrhea, but they're getting porridgey stools, and you can take a bit of syrup and that might help manage the problem better for them. Next slide, please, Anton. So going back to this 61-year-old gentleman who was referred to me for irrigation, and I called him obviously from home remotely, and to summarize his symptoms, he was passing pellety or hard stools between 1 to 5 days a week. A few days a week he was feeling urgency, and that's a really real problem because that promotes panic then. Urge incontinence was happening at least once a week, but then maybe not for 2 or 3 weeks, but there was always that risk there. And passive incontinence also is happening once a month, and that could be during the night as well. And we do a little bit on diet and fluid in that assessment that I showed you initially, and it found out from him he was drinking 600 mils of fluids a day. And I'm finding this with so many MS or neurological patients, particularly those that are using ISC, because they're so worried about drinking lots, particularly if they're going out somewhere, that it's going to be a problem, that they tend to cut down their fluid intake. And if we remember, this chap was getting recurrent UTIs and also had a history of bladder stones. So the advice I gave him regarding fluid intake was really important. So obviously we're kind of looking at 1,500, 2 litres per day. You can't jump a patient from 600 to that. They're just not going to do it. So the advice I talked through with him was, you're at 600. I want you to add in an extra cup of tea for the next week. So you're getting up to sort of 800 mils. Once you're managing that, add in another drink. So every week you're adding one more drink in to build your fluid intake up. Next slide, please, Anton. So he definitely didn't want irrigation. I told him to Google the kits that we could use with him, absolutely adamant. He didn't want it, no matter what his symptoms were. I gave him that advice regarding his fluid intake. I thought that was really important, as I do for quite a lot of them actually. And I talked through the brace and I said, okay, if you haven't been by the end of the day, use a glycerin suppository or microlax enema. Next slide, please, Anton. So review at 1 month, which was literally last week. He had increased his fluid intake and he couldn't believe it. Now, this is a bit of a miracle case, but obviously I'm doing a presentation, so I'm going to give you the good cases. But this was a phone call last week and he couldn't believe it, that actually he was now opening his bowels every day, soft stools. Problem was it was taking him about an hour. He hadn't been incontinent since he'd increased his fluid intake and was going every day, which is amazing. So some tiny bit of small information and advice can make such a massive difference. He hadn't used suppositories because he felt he hadn't needed to, but I said, do you know what, I would try one every few days because it might help with the emptying and to reduce that time that you're having to take on your bowels, which again Anton's referred to as being so important. Next slide please, Anton. TB. So this 54-year-old woman, she was passing hard stools every 3 or 4 days. This is typical with MS, this combination of constipation and incontinence together. Urge incontinence weekly. Every 2 months, she'd have just a full bowel evacuation. And she told me she's got 2 teenage daughters, and prior to lockdown, she'd taken them ice skating, had a massive accident, was in the disabled toilets for well over an hour with her girls knocking on the door saying, Mum, are you okay? Her saying, no, it's fine, I'm just sorting out. But she'd had a massive episode of incontinence. And she was also getting abdominal pain and bloating. And this is just a brief summary from all the questions that I asked her. Next slide, please, Anton. So what's her background? This woman, she's got 2 teenage daughters. In the height of lockdown, don't forget, she had them at home schooling, home with her. She'd had chemotherapy for her MS. Her mum was living next door, having been discharged from hospital at end of life care. She wasn't able to go and visit her because she'd had the chemotherapy. She'd had her wheelchair stolen from her mobility car the previous week that I spoke to her, and her oven was broken, so they weren't even able to cook meals. So this woman had huge amounts going on, which came up in the assessment. And for her, she actually didn't really want to tackle any bowel care advice. It wasn't appropriate. It was more that I was listening to her. I gave her my email, and she knew that when she's ready, she can come back to me, or if she's got any queries or worries about her bowels, that she can email me. And if I'm not sure, then I can check with Anton or one of the other doctors in our team. Next slide, please, Anton. So LP, the lady using Parasteen irrigation, actually, as with so many of these patients, it's just like, take your time, take your time. With irrigation, it's not a quick sort. You need to be using it 2 or 3 months before, with fine tweaking, before things will really improve. And things were improving. There were fewer catheter issues. I reminded her not to keep putting the catheter in and out, because that can actually end up overstimulating the bowel. And she was opening her bowels every day when I last spoke to her. Next slide, please, Anton. So I've got to sum this up now before hopefully some of you have got some questions. I think you can continue to be very effective with patients working remotely, and particularly these MS patients, neurological patients, because for some of them, coming to hospital is a huge ordeal. In London, we're seeing patients from all over the country, and some of them are coming on hospital transport. So they have to get up really early to be picked up. It can take 2 or so hours to get to us. Then they see us, then they wait an hour to come home, and then it's another 2 hours. So for them, this is actually, I think, pretty much a good way forward. Having said that, I like seeing patients in clinic and you get a better feel for what's going on. But I think for some, this has been quite a good change for the better. These patients need access to care. Give them your email and reply to them. It's just like the top of what I do. They need to know you are there for them. They think you're there 24/7. That's what they feel if you do that. Obviously, we're not. I only work 3 days a week. As soon as that email comes in on that day, I will always reply to them. Even if it's, leave this with me, I'll check for you and get back to you next week, but always reply to them. You need to be clinical with their bowel care, not pitying. address it head on. These are the symptoms. These are how we might be able to manage it, but always keeping in mind the bigger picture, with particularly with MS patients, of their overall life day to day, and fitting their bowel care in with that for them. Thank you.
Yeah, brilliant. Thanks. Brilliant, Julie. So I hope that was practical. And I'll just come to questions as they arise. And the question that's come through so far is, in patients with loaded bowel, how do you get to tolerate disimpaction with macrogol? Any advice? Do you want me to go to that, Julie?
Yeah.
Yeah. So disimpaction is quite a big deal. So the first thing to do is to confirm if this is impaction or whether it's just being constipated. Remembering, as I say, that even after a bowel action, a normal human being leaves about a third to a half of what is in there at the start still there at the end. So we don't empty our rectum out fully, even with normal bowel action. So is it actually impacted? So the consistency of the stool and how much, sorry to be blunt, how much is in there and you pop a finger in, those matter. If somebody genuinely is impacted, you're absolutely right. Trying to take things from the top end to work 25 foot further south at your bottom end, because that's how long it is from your mouth down to your anus, is quite an ask, and it runs a risk of either, number one, not working, or you take so much to make it work that you end up having incontinence, which is a miserable situation. So what we tend to do is try and encourage people to use stool softeners, not a macrogol, Movicol thing, but something like Docosate, or small doses of Movicol, which are softening without being liquefying. So keep the thing soft, but then be quite vigorous with things on the bottom end. And that may mean starting off with some glycerin suppositories, moving on to bisacodyl, maybe even a microlax. So soften the stools from the top end and use something from the bottom end, which keeps it getting out, but starting off cautiously, because people will sometimes find the idea of saying use an enema a bit of a startling thing for that. So first, confirm impaction, soften the stools, and gently step up the approach from the bottom end. And I'll keep saying, I'll keep answering. And if Julie has anything to change for the better, then she'll step in. Another question that's come up, which I think is entirely understandable. And it's a question which says that for services without a bowel care nurse, in other words, if you haven't got a Julie, how do you set that up to get that prioritized? And I probably, in some ways, it may be easier if I start with that answer to that, because Julie does the work and I sort of do the talking around it. So a few things I'd say about that. There are, the business case that managers respond to is to recognize that there's a patient need and that this is an issue around dignity. So those are kind of quite obviously incredibly key to our patients, but they're quite sort of buzz things for the non-clinical staff who make decisions about this, that patient dignity is part of this, and it's hugely prevalent. That also is a kind of a Cinderella area. It's something which they don't necessarily voice, but which has a huge impact on their quality of life. And some of the data I mentioned around expenses, the patients, when they get bowel symptoms, get more frequent UTIs, get more frequent hospitalizations, get more frequent use of services, and showing that having a service can improve that is a key thing. Now, all that said, it's still going to be unlikely that managers, especially in the current climate for the next few years post-COVID, are going to suddenly say, oh yes, here's a salary for a band 7 or band 8 to sort your bowel problems out in MS. So the question is, can you upskill in amongst all the other countless things that you do as MS specialists and the like? Do you have the bandwidth to upskill to become like a little mini Julie? And I think the thing I'd say there is that it's certainly something which we're aware of in the area, and we're trying to develop tools to help identify patients. So Julie's talked about the symptom questionnaire, that kind of thing's available. The simple advice sheets, those are available. Questionnaires and tools to identify when patients are non-responsive to therapy, those have been developed. So you can identify the patients and find them in better ways. And then the therapeutic bit, the amount of time this involves is sessional. So Julie does the MS and spinal injury work alongside being a bowel nurse for other things. So this has had to become a ambiguous services. So it has to be a part of it. So, and there are courses, and we're certainly happy to have people coming along and join us for as long as it takes to learn, in inverted commas, whatever we can help teach with. So I think it's a question of how much appetite there is on the part of the service to fill this. If there isn't an appetite, or there isn't this personnel and you're already maximally extended, then I think finding a buddy in a local rehab center which has it. So if you're near a neuro rehab center from a spinal injury point of view, they will often pick up some of the slack if they are able to. In other words, if there are, spinal cord injury centers which have a neuro rehab team, and then MS needs are not much different to the spinal injury patient's needs. So I know certain areas where that's been picked up by the neuro rehab spinal injury team. So it's difficult, it's challenging, it's not going to get easier, but there are tools to help those of you who have an appetite to do this, to acquire that. That's a very long-winded answer. I don't really give short answers to it, unfortunately.
Yeah, I think it's really interesting, actually, because I was speaking to the clinical lead in bowel and bladder management care in Hemel Hempstead on Friday, actually. And the job that she does, that she's leading, is, she said, I said, how much bowel, how much bladder? It's 70% bladder, 30% bowel. And a good majority of those patients are MS. And my feeling is the bowel often gets missed. So bladder is always kind of the priority in continence care, and historically has been. But actually, if you look at it, the bowel will be hugely a problem as well. And if that's recognized and you ask the patient, because they won't volunteer the information, it's embarrassing. They only are allowed to tell you if you ask the question, then you'll find that that is a problem. And if you're finding it's a problem, which it will be with the majority of your patients, then that kind of backs up the need that you need to do the care. So there's some basic, real basic, obvious advice that you can just give. So you don't need to be a bowel nurse specialist. If you ask the right questions, just using your common sense and having that toolkit of suppositories, medication, teaching a patient how they can use their muscles to push that brace technique, a monkey could teach it. It's so easy. The other thing is use the people, Coloplast, Coifora, Hollister, these companies that do provide all the irrigation kits. They have great teaching stuff and are hugely, hugely supportive of healthcare professionals, particularly nurses. And Anton and I have both found that. So use them as well. Yeah.
And I guess there's just a couple of things to wind off on that. One is that, yeah, I mean, that's absolutely true. So the industry colleagues are the same companies which deal with catheter stuff, also deal with bowel stuff. And there is a willingness for whatever reason. But ultimately, if it benefits our patients, that's what it takes at the time, especially when there's going to be probably a squeezing of our surface services going forward. And the other thing, of course, as I say, there will be regional centres, many of which are research active. So, and in that situation, there's often an appetite to take patients on. So I think establishing a link with a regional centre, even if you do have a little bowel service of your own, just for those patients, because as soon as you start uncovering these patients and providing the service, number one is you'll make a lot of people better, but you'll also pick up some people who are sitting on a kind of volcano. Once you expose, you think, oh goodness, why did I even start this? Because I've now got this one person in 20 who's got a horrific problem which I can't deal with. And that's the point at which you say, look, actually, we need to just pass them on. But that is important to recognize those patients, because those are the ones which, number one, sometimes they can be made very much easier with some of the complicated therapies I was mentioning that we do earlier on. But also they deserve to be treated properly, because often this is what contributes to their low mood, to their depression, to their carers, inability to cope, to their ending up in care settings. There's a lot there. So setting up a link with a research center in the area or in the distant area, most patients who are that needy of the service are prepared to do that. And as Julie was talking about there, a lot of patients will do this remotely, and actually we can provide our service remotely. So listen, thanks ever so much for the engagement. I think that's it. We've kept you going. Oh, hang on, another question. Do you teach many people how to perform abdominal massage? And if so, how do you do this remotely? Are there any resources to signpost this to? So I'll answer that if I may, because we just published something called the AMBER study, led by Doreen McClurg, which we were part of. We don't do it remotely, partly because the outcome from that study was negative. Now, remember that any clinical trial, it doesn't give you the answer for every single patient. It tells you whether it can be something which is worth setting up a service for. And what the outcome of that study was, it was broadly speaking negative, because most people couldn't be trained sufficiently to adequately improve their function. So we haven't pursued that, having done the initial study. But the principle, if you haven't, I mean, you can, Doreen McClurg, McLurg is the first author, is that you do this circular massage movements, beginning in the cecum, working your way around, spending about 7 to 12 minutes doing it as you just do little circles, about 3 or 4 centimeters wide circles, and move right to left across your cecum down to the rectum. And some patients really engage and really want to do it, and it may help some of them, but it's not something which we have pursued. So thanks ever so much for your questions. We both really appreciate that. And thank the MS Academy for inviting Julie and I to speak. And to also remind you that the next of these sessions is on the 20th, that's this Friday, 9:15 a.m. on the topic of preparing patients for online appointments. And so one final question has come up: is vibration any benefit? Never been studied in this area. There is an ongoing study in Israel looking at vibration therapy via electrical belt, but never been studied, not declared yet. Anyway, funny way to end this, but thanks ever so much for your attention, and all the very best. Take care. Take care, Julie.
Bye.